Introduction. During my work in the past years, I have experienced that most doctors are doing their best to keep up with the ever-growing number of patients, and this means an ever-growing challenge for them. While for years we have been cherishing the illusion that tumor treatment was developing, the occurrence of cancer deaths has doubled since the 1960s. Patients are still subjected to grave side effects during treatment. They have to wait long for control examinations and also for radiotherapy. Not everybody can afford to buy the newest drugs. And so, unfortunately, the number of cancer deaths is constantly growing. It must be very difficult to go on with the healing work when the doctor knows that his best knowledge, in most cases, is only sufficient for prolonging the patient's life or for relieving his pain. I recommend the following chapter to doctors healing cancer patients, and I ask them to take up the most important thoughts. I also ask them to stop for a moment in this big hustle and devote some time to sharpening the tool. They should believe that the little time needed for sharpening is worth the effort. You may ask why a researcher biologist gives advice to doctors and why he recommends an arrogantly simple method, deuterium depletion. The answer is simple. Because we are in the possession of the knowledge of the effect of deuterium depletion, and we have, for 7 years, been recording every observation result and experience considered to be any significance. We spent thousands of hours listening to patients, recording their experiences, the changes in their state, and tried to find out the possible connections between various factors. Why have we done all these? The answer is, to be able to hand over the collected experiences for everyone's benefit. I do not think that everything written down here is final and unchangeable from every aspect. Numerous questions are still to be answered. This summary was intended as a starting point for a later extensive application of DD water. With time, the majority of the observations and the main principles of application will be confirmed. Although there might be some fields where we will have to change the course described here, I am convinced that the scope of doctors' duties will alter in the new millennium. They will not have to use every effort to make maximum use of the available therapies while the patient's condition worsens, but instead, give them every help on the way to recovery. I do hope that within a short time the number of successful treatments will multiply. The history so far of deuterium depletion can be divided into 3 main phases. Ancient or Golden Age 1992-1993. The first patients. In those days we could produce greater amounts 30 L per day, 110 to 115 parts per million DD water in contrast to the 150 ppmb content of natural waters. Lacking experience. There were significant differences between individual patients. There were no dosage aspects, and we could only reach a minimal decrease of D content in the patient's bodies. Despite all these, it was clear as soon as the first patients were involved that the consumption of deuterium-depleted water had a significant and positive effect. The Middle Ages 1994-1998. Then it was possible to produce 90 to 95 ppm DD water in great quantities for 1,500 Planck length per day. It was in this period that Phase 11 clinical trials began, and the adjuvant treatment of a greater number of patients was possible due to the lower D concentration. The effectiveness of DD water improved considerably. By increasing the daily dose of DD water, we could ensure a continuous decrease of D concentration in the body for months. In the meantime, the constraints of the treatment also became clear. In patients with a considerable tumor mass, for example tumor of the colon with metastases of 5 to 6 cm in diameter in the liver, a considerable improvement or stagnation following DD water consumption was experienced. In some cases, for up to 16 to 18 months. The D concentration applied, however, was not sufficient for destroying all cancer cells. The cells, namely, which had for months been in a medium of lower D content, and because no further decrease in the concentration happened, slowly got adapted to the new medium and divided further. Then the patients again showed signs of progression. The effectiveness of the treatment considerably improved when, although in smaller quantities, DD water of 45 ppm was at our disposal. Then we tried to improve the effect by joint application of two kinds of water with different D contents. The new era. The third period began in the summer of 1998, when a 20 to 30 parts per million DD water became available. Applying various mixing rates of DD water and normal water, this ensured a longer period of decreasing the concentration in patients. The application of the substance further improved our results. The majority of observations described below are built on the application of 90 to 95 parts per million DD water in the first place, but contain the experience gained since the summer of 1998 with 20 to 30 parts per million DD water as well. I am convinced that the knowledge and information at our disposal, which we would like to share, can improve or even save the lives of tens of thousands. More than 7 years have given us the opportunity to record observations and to draw conclusions. It is a great pleasure through this book to be able to convey our knowledge to medical practitioners. How to define the effectiveness of a potential drug. We do not wish to go into details about the complex system of drug development, but would like to highlight one aspect only. If a drug for registration passes the first trials followed by further ones confirming its effect, and it does not fail in the toxicological tests either, then, after the work of 6 to 8 years, the moment arrives when it has to be proved, in clinical tests, too, that the preparation induces the effects supposed on the basis of preclinical results, in humans, too. For this, a strict system of requirements has been set up during the past decades. The aim of the painstaking preparatory process is to be able to state with absolute certainty that the changes experienced by a patient following the intake of a preparation are in fact in a cause-effect relationship. If this convincingly follows from results, and toxicological tests also allow the human consumption of the product with anti-cancer preparations, this does not mean that the potential drug is non-toxic. The product will be approved, and the preparation becomes a drug. In the case of anti-cancer drugs, clinical trials are especially important. One reason for this is that most preparations are highly toxic. Their application endangers the patient's life, and in some cases can even lead to the appearance of further tumors. With these negative side effects, only the follow-up of several hundreds or thousands of patients for years can provide the necessary information with which it can be stated that the preparation is more effective than the existing ones, or that the same effect can be reached by using it but with less side effects. The development of anti-tumor drugs has been proceeding year by year, with thousands of clinical trials, testing several thousands of future drugs, improving survival rates percent by percent. Successful clinical trials meant in most cases that, involving several thousand patients, it was proved that the given drug combination improved survival rates by 5%. This means that while the tumor allowed an average survival of 9 months, due to the new drug, these patients died 50 days later, on the average. The present system and strategy of drug development is further complicated by the fact that a great percentage of patients reacted very well to a certain future drug that manifested itself in quick tumor regression. The average survival rate, however, did not improve at all. The development of anti-tumor drugs and the concomitant system of clinical trials is similar to the construction of machines unfit for flying and to the complex system of tests to examine which of them flies further. Neither can be used for flying because they were not constructed with a knowledge of the basic laws of air current. But depending on the formation and the choice of testing, certain differences can be found between various constrictions. If, for instance, the construction is light, the drug has no serious side effects. It can fly further, or, if released from a high mountain treatment with a greater dose, it can also fly further. One thing is sure, the place of landing is rather uncertain, and in any case it is very near to the place of takeoff, whereas landing bears in itself the possibility of serious injuries or maybe the total destruction of the construction. If somebody has been testing constructions unsuitable for flying throughout his entire life, following the old schemes, and suddenly beholds a construction that flies much farther than the other ones, he is ready to think that there must have been a methodological mistake somewhere. He does not rejoice to see that at last there is something that leaves the others behind, but he begins to look for mistakes in the testing methods. The original aim, namely, to create a flying construction, becomes degraded to a secondary one. After a series of failures, there remains the excellent and sufficiently complicated testing systems. And here come the excuses. The construction did not fly farther than the others on enough occasions, the small number of patients. Certain navigation circumstances were not identical with those of the other group. The group of patients is heterogeneous. And on very rare occasions the old machines also succeeded in flying that far. Conventional therapy can also bring good results, etc. We have been listening to these criticisms for the 9th year now. While we have repeatedly proved, according to various testing aspects, that deuterium depletion is an effective means for curing cancer patients, this chapter can be understood and accepted only if the reader breaks with the tendency of development that has proved to be a dead end, and tries to accept that the anti-cancer medication based on deuterium depletion works on a principle with the help of which one can fly. To be able to state this, one does not need a statistical analysis, double-blind clinical trials, several thousand patients for a follow-up period of 3 to 5 years. The effect of the future drug based on DD water can be seen immediately in 1 to 2 months after the beginning of the treatment. After so many failures and fiascos, in the end we are able to build constructions suitable for flying. There must be a time when the first real anti-cancer drug will be produced. The theoretical background of dosage, the method of the application of DD water, and mainly of its dosage, is basically different from that of cytostatic treatment schemes used today. It is generally known that the dosage of cytostatic drugs is established on the basis of their proportion to body weight or body surface, and this same amount is applied throughout the entire protocol. There can, of course, be some alterations depending on the patient's reactions, but the generally accepted principle is to run the whole treatment with a constant amount of the cytostatic drug. Research so far has proved that the anti-cancer effect of DD water resulted from the deconcentration downshift that is brought about when an amount of water with a higher deconcentration, the water in the body of the patient, is mixed with a certain amount of water with a lower deconcentration DD water-based preparation. In vitro experiments showed that the cells, after a certain time, the 10th of June 20 hours, were adapted to the new deconcentration, which was lower than before. The adaptation means that the inhibition of cell division ceases to exist. Through in vitro experiments, it has also been proved that in cases when the lower level of deconcentration was brought about step by step, the inhibitory effect was twice as strong at the level of DNA synthesis, and also that minimally 3 times longer inhibition could be established. Numerically, this means that diminishing deconcentration in one step from 150 ppm to 30 ppm resulted in 15 to 20% inhibition of the incorporation of thymidine, and the effect gradually ceased to exist within 16 to 20 hours. If, however, The diminishing of deconcentration took place in 5 steps from 150 ppm to 42 ppm, 150 ppm, 60 ppm, 55 ppm, 46 ppm, 42 ppm. Within 48 to 72 hours, the inhibitory effect became stronger day by day and reached 40%. When establishing the dosage, we have to keep in mind that the main task is to provide an approximately similar daily level of decreasing deuterium concentration for a longer period, that is, for weeks or months. And, if this becomes impossible, to maintain a low level of deconcentration. In practice, the highest level of diminishing deconcentration in the patient's body can be reached just after the patient has started drinking DD water, with a decreasing deconcentration established in the patient's body. Later, the same amount of the daily dose causes a relatively smaller change in the level of diminishing deconcentration. In order to maintain the necessary daily decrease of deconcentration, after a certain time, 1 to 2 months, treatment should be continued with DD water of the 10th of June, 15 ppm lower D content. Then the previous concentration gradient is restored between the patient's body and the DD water to be consumed, which results in a further decrease of deconcentration. In an ideal case, the deconcentration of DD water should be fixed daily, but practice has shown that a change in every 1 to 2 weeks or 1 to 2 months is sufficient. Thus, the concentration gradient is maintainable despite the fact that the deconcentration of the patient's body had dropped significantly.